Good morning, Dr. Stadnik. I'm going to go ahead and open the lobby. Thank you.
Thibert? Are we much? Hey, good morning, everyone. Welcome to Wednesday morning rounds. A couple housekeeping issues. Due to scheduling issues, we have grand rounds a week earlier this month. So Dr. Rebecca Hahn will be presenting next week. She's coming up from New York and is presenting on a tricuspid valve and published a really nice review article last week, actually, in the New England on tricuspid valve disease. So please register to join. Today it's my pleasure to introduce Dr. Thibert. He's one of our EP fellows, our chief EP fellow, who did his original cardiology training in Vancouver and is now heading off to Victoria this summer for a staff position. So we welcome him today and look forward to your talk on PVCs.
Thank you very much. Just share my screen here and we'll get started. Okay, excellent. I think everybody can see my slides there. Thanks for having me. It's been an absolute pleasure to be here over the last 2 years. Today I'm going to talk about a topic that I've been fortunate enough to do some research in over the past couple of years. And it's a particular interest of mine. I think it is quite applicable to a lot of different subspecialties of cardiology as well as general cardiology. So without further ado, we'll get started. I don't have any disclosures. I was fortunate enough to receive the Vera Beedenland's Clinical Research Fellowship, and I did a separate project on recurrence of substrate-based ischemic VT ablation with Dr. Sadek. Just received some good news that should be coming out in publication in Heart Rhythm shortly. So the outline for the presentation, I'm going to go through a couple of cases that I think will help nicely outline the talk. We're going to talk about frequent PVCs and PVC-induced cardiomyopathy. We're going to talk about the natural history of risk stratification. We're going to talk about evidence-based management of frequent PVCs, and what happens to patients when we try to suppress their PVCs in the context of LV dysfunction. First case I'm going to present to you is a 57-year-old female who was referred to the outpatient EP clinic for management of frequent asymptomatic PVCs. She's actually noted to have frequent monomorphic PVCs, incidentally on a routine ECG. Totally healthy, no other past medical history. There's no history of syncope, no significant family history, and there's no other baseline symptoms. She's on no medications. She came in with outpatient labs, including lights and extended lights were within normal limits, as was TSH. She had a 28.4% burden of PVCs on a 24-hour Holter that was monomorphic. She had 3 runs in non-same VT up to 5 beats. Baseline echocardiogram showed normal LVEF, 56%, normal biventricular size and with no regional wall motion abnormalities, and no significant valve disease. This is her 12-lead ECG in clinic. Here you can see 3 PVCs, all of the same morphology. They have a right inferior axis. They transition the precordial leads V2 to V3, and they have some notching in V1. This is potentially suggestive of a LVO2 left coronary cusp origin. I'm not going to go through how to use the 12-lead ECG to localize PVCs or VT, but I would point particularly the trainees to this paper that was done by the Kingston group that really nicely outlines an approach to identify PVCs and VT using the 12-lead ECG. So this patient, high burden of PVCs, but was totally asymptomatic. Raises a number of different clinical questions. What's the natural history in these patients in the absence of therapy to suppress the PVCs? What are the risks of persistent PVCs? We've all heard of this term of PVC-induced cardiomyopathy. What's the risk of this, and what kind of tools can we use to stratify patients for PVC-induced cardiomyopathies? Some patients should we empirically treat these patients, these PVCs, to prevent adverse events? And what is the evidence behind therapies for PVC suppression? How well do drugs and ablation work? The second case is a little bit different. This is a 36-year-old female who was referred to EP for query PVC-induced cardiomyopathy. She was actually admitted in December of 2019 with acute decompensated heart failure 6 months postpartum. At that time, she was shown to have a dilated ventricle with an internal diameter diastole of 6.1 centimeters, an LVEF of 30% with moderate to severe functional MR. She had an MRI during the admission that showed an LVEF of 43%. There's no scar and no active inflammation. She was diuresed and discharged home on triple therapy. She was followed serially as an outpatient. There's no significant change over the next couple of years in her LVEF or her LV volumes. Now, it wasn't until she presented in a routine clinic follow-up where she had this ECG that showed ventricular bigeminy. This is a left superior axis right bundle morphology, the transitions of V3, V4, suggestive of a basal to mid LV source. But if you actually look back at her previous ECGs during admission and previous outpatient visits, she'd had 1 or 2 PVCs that were noticed on all ECGs, but she didn't actually have an outpatient Holter. When the outpatient Holter was done, they found 14% monomorphic PVCs and no non-sustained VT. And this was 18 months post-diagnosis. At that point in time, she was referred to EP for assessment. The initial thought, maybe this was a peripartum cardiomyopathy, but once this information came to light, the question was this actually a PVC-induced cardiomyopathy? So questions in this case: what is the etiology of the cardiomyopathy? What is the overall risk of PVC-induced cardiomyopathy? Is the PVC burden at least contributing to the severity of LV dysfunction if it's not the sole cause? Will suppressing PVCs improve for LV function, and could it even normalize it? And once again, what is the evidence behind therapies for PVC suppression and PVC-induced cardiomyopathy? Ventricular ectopy is something that we often see on Holter monitors in patients or any type of ambulatory outpatient ECG. Interestingly enough, in most parameters for ambulatory ECG, there's not a lot of good studies to define what is normal and what is abnormal in the healthy population. We talk about patients with frequent PVCs, how we define frequent or PVCs that we're going to worry about. There's really no consensus definition for what we would describe as frequent PVCs. There's a number of commonly used definitions: greater than 30 PVCs per hour, greater than 1,000 PVCs per 24 hours, greater than 1% burden on ambulatory ECG, or greater than 5% burden on ambulatory ECG monitoring. Our group, as you'll see later on, has used greater than 5% burden on ambulatory ECG monitoring most frequently. It far exceeds the 99th percentile PVC burden in normal individuals, while still capturing a broad population of frequent PVCs. The other thing to note about ventricular ectopy is that in patients who do have a significant amount of PVCs, there is a significant daily variation in the amount of ventricular ectopy. This is a study that I'll go more into detail a little bit later, but it was 206 patients who had 14-day patch monitors. These patients had baseline PVC burden of greater than 5%. And what they showed in these patients who had these 14-day patch monitors, but there is significant daily variation in the number of PVCs. Here in this illustration, you can see these are the patients. The blue bars represent the minimum daily PVC burden, and the red bars represent the maximum daily PVC burden. And you can see in most of those patients, there's a variation of between 5 and 10%, and sometimes even more. 34% of patients had 2 separate 24-hour periods where the PVC burden was less than 10% and greater than 20%. If you were seeing the number less than 10% and greater than 20% on one time, you'd probably manage those patients quite differently, as I would outline. So just something to keep in mind. Here in Ontario and here at the Heart Institute, we're fortunate enough that we have good access to 14-day monitoring. In British Columbia, we very infrequently use 14-day patch monitors due to limitations. So just something to keep in mind. So patients with PVCs often present with symptoms. They may feel palpitations, feel the classic, my heart skipped and I felt a big boom in my chest. They may feel lightheaded, fatigued, short of breath. Other than symptoms, why do we care? And the reason why we care is because of the resurgence of this idea that PVCs can be the sole cause of a cardiomyopathy. The interest in this came around in 1998 in this study that was actually published in the Mayo Clinic Proceedings. What they found is they looked at 14 patients who had greater than 20,000 PVCs for 24 hours and an LVEF of less than 40%. There are 4 patients who were labeled as having idiopathic non-ischemic dilated cardiomyopathy. 4 of those patients who were treated with amiodarone, they actually found that their LVEF increased from a mean of 27% to 49%, and they had significant improvement in their functional class. So on the basis of this, there started to be interest in studying PVCs more, and this idea that PVCs alone could be causing systolic dysfunction and can be potentially reversed with PVC suppression. There's a number of potential mechanisms for the induction of PVC cardiomyopathy. There's no real consensus as to what the cause is, but it's likely multifactorial. Things such as interventricular desynchrony and interventricular torsional changes in the context of frequent PVCs. When you have PVCs, you often have a pause that can increase LV filling. So there's some theories that it may be similar to chronic valvular regurgitation. There's been shown to be alterations in calcium channel handling. And interestingly, there's been shown to be some LV remodeling in animal models. There's a couple studies where they paced pigs from the RV apex and from the LV. They essentially introduced 50% PVC burden, so PVCs in a pattern of bigeminy, and followed them over time. They did electroanatomic mapping at baseline as well as after withdrawal of PVCs. And what they found was when they had PVCs, their LV systolic function decreased, and when they withdrew the PVCs, in about 4 weeks, the LV systolic function improved. However, on electroanatomic mapping after normalization of EF, there was some voltage abnormalities suggesting of some scar. So this was also confirmed in autopsy studies, suggesting that even though when you withdraw the PVCs, the LVEF improves, there still is some LV remodeling and there is some scarring that happens as a result. There's an interesting study that was also recently published last year in JACC-EP that is quite hypothesis generating in the etiology of frequent PVCs. So what they did was they took 56 patients who were referred for catheter ablation for frequent PVCs. What they did was during sinus rhythm, the sinus beat preceding the PVC, and during the PVC, they measured global longitudinal strain, desynchrony, and dyssynergy on echocardiogram. And what they found in the sinus beat prior to the PVCs, there was significant decrease in global longitudinal strain and significant increases in desynchrony and dyssynergy, suggesting what they call the heart had a premonition that the PVC was going to occur. They hypothesized this may be related to increases in sympathetic tone and that there's cellular processes that may underlie the generation of PVCs, and the heart actually knows that the PVC is going to come. There's certainly more studies that need to be done in this area. It's certainly quite interesting. So I think I've shown you some data, this idea of systolic dysfunction in the context of frequent PVCs does happen. We see a lot of patients who come into the clinic who have frequent PVCs, who have no significant history, no structural heart disease at baseline. So the number of questions in this is really how many patients actually will go on to develop LV systolic dysfunction, and what happens to the PVCs over time? Can they spontaneously resolve? Will they progress, or will you always have them? There's actually a few studies looking at the natural history of untreated PVCs. This is one of the studies that was published by Andrea Lee when she was a cardiology resident at UBC, with Mark Dale as a lead author, who's done a number of studies in this and has been my research mentor. This was published back in Heart in 2019, and it was only 100 patients. This is, at the time, was kind of the biggest natural history paper in patients with frequent PVCs and preserved LV function. We've actually updated this analysis, and it's we have submitted a manuscript that's under review with Heart Rhythm. So I'm going to present that data to you today. So what we did was we took 487 patients who were referred to the British Columbia PVC registry. We defined frequent PVCs as having greater than or equal to 5% on ambulatory ECG monitoring. We excluded patients who had any evidence of structural heart disease if they had a previous myocardial infarction, LVEF less than 50%. If they did have non-ischemic patterns on imaging and a preserved EF, we did exclude those. We also excluded patients who had mitral valve prolapse because of the potential for malignant mitral valve prolapse syndrome and the association with PVCs and sudden death. We also excluded patients who had come into the registry on antiarrhythmic drugs or who had a previous catheter ablation. and we excluded patients who didn't have serial echocardiograms or ECGs for analysis. We ultimately ended up with 270 patients for our analysis. Just to give you an idea of what happens in the PVC registry there, is the patients are referred to the BC PVC registry by being referred to one of the electrophysiologists at Vancouver General Hospital or St. Paul's Hospital. They have a baseline visit, including an ECG, Holter monitor, echocardiogram, as well as baseline blood work. A cardiac MRI is recommended, if not done prior to that at that time. We'll talk about why a little bit shortly. These patients are followed serially. In the absence of any significant symptoms or development of LV dysfunction, the goal is to manage them conservatively without any antiarrhythmic drugs, catheter ablation, and even beta blockers or non-dihydropyridine calcium channel blockers. So if they're minimally or asymptomatic, even if they have high PVC burden, they're serially followed every 6 months with 24-hour Holter. They have echocardiograms every year. And then if they're stable at 24 months, 2 years, they change the monitoring to serial Holters and echocardiograms every 24 months. So in our population of 270 patients, who had untreated PVCs and preserved EF, which we defined as greater than 50%, the mean age of these patients was 55 years. 56% were female, and a mean LVEF of 59.5% with a standard deviation of 5.1. They had quite a high PVC burden at baseline. On their initial ambulatory ECG, the burden was 17.5% with an interquartile range of 11.5 to 25.7. And on any Holter monitor, the median maximum burden was 22.2% with an interquartile range of 15.2 to 31.6. Just over 2/3 of these patients had outflow tract PVC, so RVOT or LVOT. So what we did was we followed these patients for the development of adverse clinical outcomes, as well as to see what the natural history of the PVC burden was. When we look at the clinical outcomes at a median follow-up of 27 months, 4.4% of patients developed LV dysfunction, defined as a drop in LVEF to less than 50%. There is only one patient who had heart failure hospitalization, accounting for 0.4%. There was no all-cause deaths. We did look at which patients would ultimately require specific therapy to suppress PVCs. That occurred in 13.7%. 4.4% of those patients were the patients who had LV dysfunction less than 50% EF. There was another 4% of patients who had borderline drops in EF and who went on to have suppressive therapy, and the remainder of the patients had either antiarrhythmic drugs or catheter ablation for symptoms alone. If you look at the time to the clinical event, so as I mentioned, the adverse event rate is 4.8%, which is predominantly a drop in LVEF to less than 50%. It took a long time for these patients to develop drops in their LVEFs. Here on the left, you could see time to clinical event stratified by PVC burden on initial ambulatory monitor, but the median time to event was 49 months with a range of 8 to 109 and an interquartile range of 29.5 to 63.5. Their median lowest LVEF was 46%, and the lowest LVEF seen in patients who had a drop in EF was 40%. So this goes to show you that these patients, if they're going to have an adverse event, predominantly LV dysfunction, it takes a significant amount of time for this to develop, and you shouldn't expect them to come in cardiogenic shock with an LVEF of 20 to 25%. The next question is, what was the natural history of their PVC burden? We defined a primary arrhythmic outcome as spontaneous reduction in PVC burden to less than 1%. We found that 43.7% of patients had spontaneous reduction to less than 1%. So in the absence of antiarrhythmic drugs or catheter ablation, at a median of 17 months with an interquartile range of 9 to 31. Here you can see on the left the curve for time to reduction PVCs less than 1%. We did do confirmatory monitors in most patients after their spontaneous resolution. There was only 12% of patients who didn't have confirmatory monitors, but 70% of patients had documented reduction of PVC burden to less than 1% on 2 outpatient Holter monitors, at least 6 months apart. There was, in this population, 8 of the 118 patients, or the 43.7% who did have reduction in EF or PVC burden to less than 1%. There's an increase back to greater than 1% in 18%, and an increase in greater than 5% in 11% of patients. So there are a number of patients who will resolve and then bounce back. The vast majority of them who do resolve will stay resolved for a period of time. We did look at multivariate, we did do a multivariate analysis and looked at predictors of PVC persistence. We found that maximum PVC burden of greater than 20% was associated with PVC persistence, as was non-sustained ventricular tachycardia, which we defined as having greater than 3 beats of ventricular, three consecutive ventricular beats at a rate of greater than 100 beats a minute. The initial PVC burden, as you can see on the left-hand side, was not a multivariate predictor of persistence, but keep in mind PVCs change over time and a maximum burden was. There were a number of predictors of resolution. Interestingly, having an age greater than 60 at the time of their initial ambulatory ECG of over 5% burden was predictive of resolution, as was native right bundle branch block. There are few patients who had right bundle branch block. You can see there that the confidence interval was quite wide, as was indeterminate PVC morphology. And those were just patients who on their first ECG didn't have a PVC to identify the morphology. Those are likely patients who are already on their way to resolution or who had resolved. So certainly, I think that this shows us, that if you just kind of sit and hold tight on a lot of patients, they will have spontaneous resolution of their symptoms, and we don't have to expose them to the antiarrhythmic drugs, which do have side effects, or catheter ablation. But there is about 5% of patients who will go on to develop adverse events. So how can we tease out, how can we risk stratify those patients who will have adverse events, and what can we do potentially to prevent that? So there's a number of different tools for risk stratification. One that has been widely studied in a number of small observational studies is ECG predictors. So PVC burden, site of PVC origin, PVC QRS duration, and PVC coupling interval are the most commonly studied ones. PVC burden has consistently been shown to be associated with the development of cardiomyopathy. This is some data from 174 patients who were sent for catheter ablation for PVCs. They showed that having a PVC burden of greater than or equal to 24% and ROC of 0.89 for decreased LVEF. However, patients still had a reversible cardiomyopathy if they only had 10% burden. Now, maybe it's just because they had 10% burden, or maybe they were measured on a day where the PVC burden was lower. But certainly it seems to be consistent. The messaging is that, if you have higher burden of PVCs, you're at increased risk. Site of origin has also in multiple studies been shown to be important, particularly having epicardial PVCs, so really wide slurred PVCs have been associated with LV dysfunction. Going along with that theme, having a wider QRS duration has also been shown to be associated with development of LV dysfunction. Interestingly, the wider the PVC QRS is, the less likely they are to have a reversible cardiomyopathy. This was in a study of 294 patients with frequent PVCs who were referred for ablation. PVC coupling interval has also been studied. Interpolated PVCs, as you can see here by this illustration, are PVCs that don't interrupt the next sinus beat. So they're often sandwiched tightly between two conductive beats. Interpolation in one small study has been shown to independently predict cardiomyopathy, as in another study, coupling variability. Coupling interval is the time between the previous conductive beat and the PVC. So coupling interval variability has also been shown to be associated with a risk of cardiomyopathy. So these are all things that we could easily look at the ECG. The studies are not great. They're observational, small numbers, but things that you could potentially pick up as clues as that maybe patients we should keep a closer eye on, but not something that I would go ahead and perform empiric therapy for. Like many things we've done in medicine, we try to use multiple variables to try to identify risk scores and make risk scores, that may allow us to better risk stratify patients. This was an interesting study that came out of the group from UCSF, who's done a lot of research in this area. It was 206 patients with a PVC burden of greater than equal 5% on 14-day patch monitors, LVEF greater than 45%. They excluded patients who had fibrosis on MRI. And what they did was they looked at variables that were associated with LV remodeling, defined as a drop in LVEF to less than 45%, or LV dilatation, defined as LV end diastolic volume index of greater than 75 milliliters per meter square. So what they found in their multivariate analysis was having non-sustained VT, having a PVC coupling interval greater than 500 milliseconds, having a superior PVC axis, and having a PVC burden greater than 10% were significantly associated with LV remodeling. On the basis of those odds ratios, they made the ABC VT risk score, axis burden, coupling interval, ventricular tachycardia, getting most points for VT, coupling interval, and having a burden greater than 20%. You then count up the number of points, and they would define patients with low risk, 0 to 4 points, intermediate risk, 5 to 8 points, and high risk, 9 to 12 points. They then did is they used the original derivation cohort as well as this depicted separate Korean validation cohort to try to validate the risk score, and they did this in the same paper. What they found was having an increased ABCVT risk score was associated with an increased risk of events, which is a primary composite of freedom from cardiovascular mortality, LVEF drop by 10%, or heart failure hospitalization. You can see here from the curves that more patients who had higher risk scores, intermediate or high risk, had events. Keep in mind that the vast majority of these patients at a significant amount of follow-up didn't have events. And if you look in this validation cohort, there's only 19 events, which was 3.4% of patients. And the ABCVT risk score in those 19 patients ranged from 2 to 11. In the paper, they propose a score of greater than 5 as being a cutoff for having patients with high risk. This risk score, I think, has been a good attempt at combining these variables, but hasn't been properly validated up into in multiple different cohorts. We attempted to validate, or we did validate, the ABCVT risk score in the BC PVC registry. This was some data that we published back in 2021. So we took 201 patients from our registry who had PVC burden of greater than or equal to 5% and LVEF greater than 50%. Found that most patients were low risk, 61%. 35% of patients were intermediate risk, and there's only 4% of patients that were high risk. We looked at the same primary composite endpoint, freedom from cardiovascular mortality, decrease in EF by 10%, or heart failure hospitalization. We found there was 11 total events, 5.4%. 5 patients were low risk, and 6 patients were intermediate or moderate risk. We did Cox proportional hazard modeling, and for the Cox model, measures of discrimination were quite poor. The Herald C index was 0.57. So in our external validation of this risk score, we felt that it wasn't great in predicting risk of these events and those who have frequent PVCs. And it should potentially be used with caution in patients who have frequent PVCs, because a lot of patients will not have events. And it's very controversial whether or not we should be performing an empiric therapy in those who we deem are high risk. Are there any other risk stratification tools that we could use in these patients to help predict risk? Cardiac MRI is an imaging modality that's increasingly utilized in patients with non-ischemic cardiomyopathy, particularly hypertrophic cardiomyopathy, to assess for arrhythmic risk and risk of adverse events. So there is some literature on using cardiac MRI for risk stratifying patients with frequent PVCs. So one previous study that I'll describe here. So this was patients who were apparently healthy. There's 518 patients who had frequent PVCs defined as greater than 1,000 PVCs per 24 hours. And on their baseline assessment, they had normal ECGs and normal echocardiograms. Their mean age was 44, and actually 75% of these patients were actually just being routinely screened for sports eligibility. So what they did was they performed cardiac MRIs in all these patients to see what percentage had cardiac MRI abnormalities. They found that despite having a normal echocardiogram, they found concealed cardiac MRI abnormalities in 16% of patients. The majority of these were LV abnormalities in the form of LV-LGE, the most common location being basal inferolateral in 48%. They looked at predictors of having MRI abnormalities. Clinical predictors that were significant in multivariate analysis included advanced age, male gender, family history of sudden cardiac death or cardiomyopathy, and unexplained syncope. With respect to the PVC morphology, if you had multifocal PVCs or a non-left bundle and non-inferior axis PVC morphology, you were much more likely to have there's a significant increase of cardiac MRI abnormalities. Here you could see that if you had a right bundle superior axis PVC or multifocal PVCs, 70% of those patients had MRI abnormalities. So those would be morphologies that you should be really on the lookout for having underlying MRI abnormalities. But what do those MRI abnormalities mean? So they actually looked over time at adverse events, defined as sudden cardiac death, resuscitated cardiac arrest, and ICD shocks. They found with patients with cardiac MRI abnormalities, you can see here depicted in these curves, had significant increase in this composite event. Over 67 months of follow-up, the primary outcome occurred 5% overall, which is not an insignificant amount. 29% of patients with MRI abnormalities versus 0.2% of those without. So certainly this would suggest that having MRI abnormalities does place you at increased risk for adverse events, and the risk of adverse events in that population is not low. Once again, the question is what do we do with these patients? The event rate we thought was a little bit on the high side. And it wasn't a very generalized population, having 74% who were just sent in for routine screening for sports eligibility. So we performed a very similar study. We replicated this study in our BC PVC registry, and this was published last year, last September in JACC EP. So we very similarly took patients with frequent PVCs, which we defined as greater than 5% at 24 hours, who had no structural heart disease on echo. We also excluded patients who had a history of myocardial infarction. One thing that we did was we included patients who had LVEFs 30% or above. The reasoning at that time was that it can be quite difficult to assess LVEF in the context of frequent PVCs. The mean age was higher in this study, 55 with a standard deviation of 16. We found that 14% of patients, so quite similar to the previous paper, had cardiac MRI abnormalities. If you look at table 3 here, looking at all patients versus those who had LVEF greater than 50% or LVEF less than 50%, there's a significant increase in MRI abnormalities if you had a lower EF, which is not surprising. So 31% of patients had abnormal MRIs if their EF was less than 50%. Most of the abnormalities are LV-LGE and a non-ischemic distribution, as well as some patients who had unidentified regional wall motion abnormalities. Predictors of abnormal MRI in our population was age greater than 60, having multifocal PVCs and non-outflow tract LV PVC origin, which is similar to the previous study. We also found that basal inferolateral was the most common site for these concealed MRI abnormalities. And we found that the 12-lead PVC origin corresponded to the site of LGE in 61% of patients. There are some limitations to PVC localization on 12-lead. Keep in mind, there's 26% of patients who didn't have the origin corresponding to the area of LGE who had RVOT PVCs. So it may just be unrelated idiopathic RVOT PVCs with concomitant incidentally detected LGE abnormalities. We did also look at adverse events in our population, which we defined as mortality, sustained VT, a reduction in EF greater than 10%. Median follow-up for us was 36 months. And what we found was you had a significantly increased risk of adverse events if you had a cardiac MRI abnormality. And the predictors in multivariate analysis of the composite adverse outcome was having an abnormal MRI, not surprisingly having a left bundle branch block and having non-sustained VT, and having non-outflow tract PVC origin. Most of these patients or most of these events were decreases in LVEF to less than 50%, so that occurred in 3.5%. However, there were 3 patients who had sustained VT and 3 patients who had death. So certainly I think that these studies show us that MRI can potentially be useful in these patients who do have a structurally normal heart on echocardiogram to identify those who have concealed abnormalities, and those concealed abnormalities are associated with increased risk. The question is, what do we do with those patients, and how can we further stratify the risk? One potential and one proposed and studied way to do that further after an abnormal MRI is by doing programmed ventricular stimulation. The role for programmed ventricular stimulation remains quite limited in our field. I know Dr. Burney is doing it for his cardiac sarcoid patients who have LGE, and there are a number of other indications for it. So there's a couple studies that actually looked at patients who had frequent PVCs, predominantly normal EFs, who had cardiac MRI and who did a VT stim test prior to catheter ablation. This was a study that was published in 2017. It was 321 patients. What they found is 80% of patients had no structural heart disease, and of those patients, only 1 patient had inducible monomorphic VT. They did a VT ablation. They didn't give that patient an ICD. In the 20% who had structural heart disease on MRI, it's interesting that they found actually 22% of patients had sustained monomorphic VT and went on to have an ICD implanted. That was quite a bit higher than what I would have expected. And if you look at long-term outcomes in these patients, composite endpoint, this was survival-free of VT or VF. If you look at the curves, blue is no structural heart disease and no inducible VT. You had structural heart disease and no inducible VT. Survival was quite good with very few events. But if you had structural heart disease and inducible VT, despite having implantation of an ICD, the rate of VT-VF or death obviously was significantly increased. There's another study that was quite similar that was published in 2020. This was 272 patients, very similar baseline PVC burden, LVEF, with 50% of patients having an LVEF less than 35%. In this study, they found similarly 25% of patients had scar on cardiac MRI. And those who didn't have scar, there was no inducible VT. So having no scar on MRI seems to be quite good for ruling out inducible VT. In their study, they found 10.4% of patients, so 7 out of the 67, had inducible monomorphic VT pre-ablation with a VT stim. They did look at the mean scar size in those who had inducible VT versus those who did not. The mean scar size was greater in those who had inducible VT with a mean scar size of 9.3 centimeters cubed versus those who had non-inducible VT, the mean scar size of 1.6 centimeters cubed. They also did an analysis. They found an ROC cutoff of 3.4 centimeters cubed, an area under the curve of 0.97 was set with a sensitivity of 90% and specificity of 100%. I think in theory, this is very logical. Higher scar volume is associated with inducibility. And I think the higher scar volume would also be suggestive that this is an underlying cardiomyopathy where frequent PVCs are just a component of that. And frequent PVCs may actually be a risk factor for adverse events themselves. I think in terms of looking at MRIs and looking at scar volume, from what I have been told, it's quite challenging, particularly in the context of having frequent PVCs, to accurately measure the scar volume, and that there's quite a bit of inter-observer variability. So the practical use of this may be limited, but is certainly thought-provoking. So how do we best manage these patients believed to be high risk? The answer is that we really don't know. So if you have no MRI abnormalities, and no other significant history, you're likely to be quite low risk. But in those who are high risk, who have some of these high risk features, what should we do? The answer is we don't know. Should we be doing catheter ablation, and will PVC suppression reduce the risk? If you have an abnormal MRI, should we be doing VT stim? That hasn't made the guidelines. If we do VT stim, should we implant the ICD? Should we do longer term rhythm monitoring if they have high risk features and maybe some symptoms of lightheadedness or sustained palpitations? Should we implant an ILR? And I think an ever evolving role is what is the role in genetic testing for identifying potential non-ischemic or arrhythmogenic cardiomyopathies in these patients. And these are all questions that I have. A lot of that is very thought-provoking, but what is the best clinical approach to these types of patients? Patients who have PVCs in the absence of structural heart disease and those who have frequent PVCs with reduced EF. I'm going to take some time to go through that. I point everybody in the direction of the 2022 ESC guideline for the management of patients with ventricular arrhythmias and prevention of sudden cardiac death. This was just published last year. I think they've done a great job with this guideline, and they do have a nice section on frequent PVCs with very easy to follow flowcharts. So I'm actually going to go through those and provide some commentary as to their recommendations for these patients. So they recommend in patients with PVCs or monomorphic VT and no apparent structural heart disease, you have baseline assessment with ECG, echo, and ECG, echo, and Holter. They describe, if you have an inclusive assessment for the etiology, or they have atypical presentation that they define as older age, a right bundle branch morphology of the PVC or VT coming from the left ventricle, or sustained VT. At that point, they would recommend a cardiac MRI with a class 2A recommendation. I think that I've shown some literature that suggests that MRIs is good at risk stratifying. It's also helpful in procedural planning if you're going to do a catheter ablation in these patients, because you're going to want to know what the scar burden is, because it's going to potentially significantly change your ablation strategy as well as your approach to the ablation. So say they've had an MRI and they've thought to have no structural heart disease, we could label them as idiopathic PVCs. The first question is does these patients have significant symptoms? And that really becomes the first point in indications for treatment of these patients, in the absence of any adverse events. So if they don't have any symptoms, they say, if they're less than 10% PVC burden, you could discharge them. If they have between 10 and 20% PVC burden or greater than 20% PVCs, you could regularly follow them with serial echocardiograms to assess for LV dysfunction, and that comes with a class 1 recommendation. And I think that that's reasonable. I would probably follow patients who have PVC burdens greater than 5%, at least for a period of time, just knowing that they have significant variability. I thought 10% was a little bit on the high side. Interestingly, also put catheter ablation as a 2B recommendation for patients who are asymptomatic with greater than 20% PVCs. It is a 2B recommendation. I would disagree with that just based on the data that I've shown you, that a high percentage of these patients will resolve, and that it takes us, quite a long time for these patients to develop adverse events. If they have symptoms, they suggest looking at the PVC morphology. If it's RVOT or fascicular in nature, or if it's not RVOT or fascicular in nature, they would recommend beta blockers or calcium channel blockers with a class 1 recommendation, flecainide or catheter ablation with a class 2A. And if they do have RVOT or fascicular PVCs, they would recommend catheter ablation as a class 1. Reason for that, particularly with RVOT, is it's the most successful site of catheter ablation, which I'll show you shortly. They recommend beta blockers, calcium channel blockers, or flecainide with a 2A recommendation. What about patients who have greater than 10% PVC burden and mildly reduced or reduced LVEF? Certainly you want to assess if they have baseline known structural heart disease. If they don't, is there any suspicion of coronary artery disease, valvular heart disease, or inflammatory heart disease? If that's not the case, they do recommend a cardiac MRI with a class 2A recommendation. The reason for that is to assess whether or not there's any LGE, because they use this as their decision tree as to whether or not they think this is a PVC-induced cardiomyopathy or not. So if there is no LGE, they suspect that maybe all the PVCs are a result of the cardiomyopathy, or the PVCs result in the cardiomyopathy, and catheter ablation should be considered with a class 1 recommendation, antiarrhythmic drugs with a class 2A. If there is LGE, this is potentially structural heart disease that is being aggravated by frequent PVCs, and they give a 2A recommendation for catheter ablation and amiodarone. There is also patients who we know who have structural heart disease who do have frequent PVCs, and it's one of those things, is the chicken or is it the egg? So, if the degree of LV dysfunction is out of keeping with their underlying heart disease, this may be suggestive that the PVCs are actually aggravating the cardiomyopathy, and maybe treatment of the PVCs will potentially reverse some of their LV dysfunction. Now, I want to go through the evidence behind these therapies aimed at suppressing PVCs. Despite us using a lot of these agents quite frequently, I think that the evidence in this field is quite limited. I want to briefly touch on non-pharmacologic management. This was a cardiovascular health study, 1,424 patients with serial Holter monitors. The mainstays in terms of non-pharmacologic management, they showed that no or low intensity exercise versus moderate or intense physical exercise, current or ex-smokers versus non-smokers having increased systolic blood pressure has been associated with more PVCs. There's a recently published study that was quite interesting in a health population that showed there was more PVCs on days where caffeine was consumed versus not, but that hasn't been studied in the population of frequent PVCs. So when you're thinking about lifestyle management and non-pharmacologic management, maybe some other non-specific therapies, these are things that you might want to talk to your patients about. What is the evidence for pharmacologic therapy with frequent PVCs? As I mentioned previously, if you don't have RVOT or fascicular PVCs, ESC would recommend beta blockers or non-dihydropyridine calcium channel blockers as a class 1 recommendation. For all patients with frequent PVCs in the absence of documented structural heart disease, the AHA-HRS guideline from 2017 would also recommend this with a class 1 recommendation. If you look at what the literature is for these medications as well as catheter ablation for suppressing PVCs, this study from 2014 is quite widely cited and used, and you'll see it pop up in a number of review papers. This was 510 patients with over 1,000 PVCs for 24 hours who were treated with ablation or antiarrhythmic drug therapy. So what they looked at was baseline and after treatment with these medications, radiofrequency ablation. So they found with beta blockers, calcium channel blockers, there was a significant decrease in PVC burden in a 24-hour period by 36% and 43% respectively for beta blockers and calcium channel blockers. Patients who were receiving class 1 or class 3 antiarrhythmic drugs had a much higher PVC burden at baseline, and they had significant reductions, as you could see there, in their PVC burden after therapy. Radiofrequency ablation was similar to antiarrhythmic drugs, really high burden of PVCs at baseline, over almost 25,000 per 24 hours, with significant reduction with radiofrequency ablation. Now, if you look at this, you say, well, beta blockers and calcium channel blockers work. Maybe we should, we should just use them first line in all of our patients. Problem is, this population is often a younger population of patients who have low resting heart rates. They're also a population who tend to poorly tolerate beta blockers and have significant side effects. And one of the issues with this study was there's actually no control group. This is an observational study. There's no control group, and I've already shown you that there's a high rate of spontaneous resolution in this population. So how do we actually know that beta blockers, calcium channel blockers are actually having that effect? So we looked at this in our BC PVC registry. We looked at 120 patients who had preserved LVEF and who had frequent PVCs. So what we did was we looked at baseline therapy and post-intervention, or baseline PVC burden and post-intervention PVC burden. Here you could see if you got no medications at all, not surprisingly, your PVC burden daily reduced by 32%. If you were on beta blockers or calcium channel blockers, it decreased by 30.5%. If you take into the account the median daily PVC burden, beta blockers and calcium channel blockers did not significantly reduce the amount of PVCs compared to conservative therapy. It was suggesting some evidence when obviously it's an observational study and it's small, but when you do throw in a control group, maybe beta blockers and non-dihydropyridine calcium channel blockers have no significant effect when you compare it to conservative therapy, where a lot of patients will have variation in spontaneous resolution. What about antiarrhythmic drugs? Amiodarone, flecainide, and sotalol have been the most studied. In our small cohort here, there was only 27 patients who were on class 1 and class 3 antiarrhythmics, but we did find an 81.3% reduction in their median daily PVC burden, which was significantly reduced compared to those with conservative therapy. Amiodarone itself, has been more widely studied. Amiodarone appears to suppress PVCs better than sotalol. The one randomized trial with sotalol showed that only a dose of 200 milligrams BID was associated with PVC reduction, and only 14% of patients went on to have reductions greater than 75%. Greater than 80% PVC reduction, I'll show you shortly, has been associated with reversal of PVC-induced cardiomyopathy. Now, obviously, sotalol has a number of risks. Flecainide is used commonly in patients who have no structural heart disease, no coronary disease. There's not a lot of studies, but it does appear to be effective. So what about catheter ablation? In that initial study I showed you, catheter ablation significantly reduced PVC burden. And there's many studies that have shown, compared to antiarrhythmic drugs, that catheter ablation is better at suppressing PVCs. This was a case here that was done at the Heart Institute. I'm not going to go into how to do a PVC ablation. This essentially is an electroanatomic map of the RVOT. Anterior surface is a free wall, and what we do is we look at the local time of activation and try to get the earliest time and reference the surface QRS. That's denoted by the red pin here. Provide radiofrequency energy there in attempts to suppress the PVC. So what's the success of catheter ablation overall? So this is 1,185 patients who had normal LVEF and a mean PVC, who had high PVC burden at baseline, who underwent catheter ablation at 8 different centers between 2004 and 2013. Overall success rate was 84%. It was highly dependent on the site of origin. You can see here, this is by site as well as by single or multiple PVCs. RVOT PVC origin was the only independent predictor of success in the absence of antiarrhythmic drugs. You could see here that the worst success was seen in epicardial, papillary muscle, and multiple PVC morphologies. Although in general, outside of epicardial PVCs, acute procedural success does tend to be greater than 75%. In the absence of antiarrhythmic drugs, all of these are over 65%, and with antiarrhythmic drugs, this long-term success ranges from 70 to 95%. Once again, with sites being most successful from the LVOT and the RVOT. Recurrence rates overall were about 10%. The complications of catheter ablation were low, overall 2.4%, most of which were major groin complications, 1.3%. So certainly catheter ablation is an effective procedure. How successful we are with the procedure really depends on the site of origin, and there is minimal complications. Lastly, I just wanted to touch on the outcomes of suppressive therapy in patients with reduced LV systolic functions. If you look at the outcomes in patients with low LVEF, the question is really how do we define success in suppression of PVCs with these patients? So obviously you need to have suppression of PVCs. This success defined as a normalization of VF, LVEF greater than 50%, or is it successful if you have an LVEF improvement of greater than 10 to 15%? This is just some data from the CHF STAT study, which you may remember was a study published in the 90s in New England Journal, looking at amiodarone in patients who had frequent PVCs and LVEF less than 40%. And what they found was 72% of patients, so patients who resolve PVCs are in blue. So 72% of patients had suppression as PVCs, defined as greater than 80% reduction in burden. There's only 14% of patients who had resolution in the placebo arm. 29% on amiodarone had recovery, had suppression of their LVEF, and recovery defined as recovery in LVEF greater than 10%, whereas only 4% of patients in the placebo group did. If you look at patients who had PVC suppression and recovery of their LVEF by greater than 10%, over time there's a significant reduced outcome of VTVF or death in those populations. So those patients tend to do better. However, there still is a large percent of patients, 43% in amiodarone, that had PVC suppression and didn't have significant changes in their LVEF. Only 11.6% of patients actually had LVEF improve to greater than 50%. So in this study, not a lot of these patients are completely normalizing. Certainly PVC suppression seems to improve the LVEF in a number of patients, but not all of them. If you look at the outcomes of catheter ablation trials in those with LVEF, there's not a whole ton. It's all observational, the largest of which was published in 2015, which is 245 patients. So the 2/3 will have greater than 10% increase in LVEF post-ablation, which is pretty good. And only in those who have greater than 80% suppression will have improved LVEF in size. So that is a number we should be aiming for with therapies for antiarrhythmic drugs and catheter ablation. Unfortunately, 15% of patients had no improvement, and 18% of patients had less than 10% improvement, which is likely clinically insignificant. There are a number of different predictors of reversible cardiomyopathy for these patients when going for catheter ablation. Obviously, the absence of pre-existing diagnosed cardiomyopathy. As I mentioned previously, having an increased PVC QRS duration was associated with less chance of recovery. There are some small studies looking at the scar mass seen on an MRI. So the two studies that do exist are small. This is one of 70 consecutive patients. So essentially, in multivariate analysis, they showed that if you had more scar mass, you were less likely to have reversal of your LV dysfunction. Here in this diagram, you could see this is scar mass on the y-axis in grams. The line is at 9. So if you had, there's many more people who responded who had less than 9 grams of scar mass versus those who had greater than 9. I didn't include in this talk, but I just wanted to just briefly, mention the catheter ablation is effective in patients who have low biventricular pacing percentage with frequent PVCs. So if you see patients who have low biventricular pacing percentage with CRT and have monomorphic PVCs, ablation has been associated with improvements in their biventricular pacing to target, as well as significant improvements in their LVEF. Concluding the cases, so case 1, 57-year-old female who had asymptomatic monomorphic PVCs, a 28% burden from the LVOT. She went on to have an MRI that showed no abnormalities. So she was, the decision at that time was made to wait and watch with no therapy, including no beta blockers. You can see here serial Holter monitors. And eventually, despite having high burden, she spontaneously resolves in April 2020, 0.24% burden. January 2021, her burden persistently remains less than 1%. Serial echocardiograms showed no deterioration of LV dysfunction. This was a patient who was totally asymptomatic. We just waited and watched, and we had spontaneous resolution in the absence of therapy. So one of the points I wanted to drive home. The second case was a 36-year-old female who had 14% burden, LV septal origin. She went for a PVC ablation here at the Heart Institute. This is an ECG pre-procedure. The PVCs were mapped to the basal septum of the LV. The procedure was acutely successful with suppression of PVCs. If you look at the 14-day Holter monitors after the procedure in February 2022, That's 14-day Holter monitor. She had 3 PVC totals and 20 PVCs total on those 14 days afterwards. Eventually, her LVEF comes up from 45 to 50% in May 2022. March 2023, she has normal LVEF, and she's being withdrawn on her goal-directed medical therapy. So is this an example of PVC-induced cardiomyopathy? Potentially, there's a number of confounders in this case: peripartum period, optimal medical therapy, but certainly a good outcome from this patient. I want any take-home messages and all the talking that I've done here. I think that these are them. Ventricular ectopy is common. Adverse events occur in 5% and take time to develop. There's a high rate of spontaneous resolution. Conservative management is safe in those with minimal or no symptoms. Risk stratification for adverse events is challenging. Cardiac MRI is useful for risk stratification as well as for procedural planning, but further research is warranted how to best identify these patients and how to modify their risks. PVC suppression can improve LVEF. It might not always, and it may not always improve mortality. And that catheter ablation is the most effective treatment for PVC suppression. There's a number of limitations that exist. I would have loved to get into the novel methods that may help improve procedural success for PVCs, but I didn't have time. I just wanted to thank a number of people over the last 2 years. The EP group here has been very supportive of me throughout my training. An absolute pleasure to work with everyone. The endowed Beanlands Research Fellowship, Dr. Mark Dale, who continues to be a research mentor for me from Vancouver, the Royal Jubilee Hospital for giving me a job and for mentoring throughout the process, as well as my family at home. That's my wife, Martha, our almost 1-year-old daughter, Josephine, and our almost 4-year-old daughter, Elizabeth, who made a lot of sacrifices to get me through my training and get me to the end stages. Sorry, it's a little bit long. I'll take any questions at this time.
Michael, thank you. That's excellent. If anyone has questions, you can raise your hand here and we'll give you a microphone. Otherwise, you can type your message into the chat box. There is a comment from Dr. Nair just complimenting your presentation, Michael, on the topic. Also, there's a question from Dr. Johnson. So his question is, what would you consider a definition for frequent PVCs? So 5%, 10%, 1,000 PVCs per hour. Practically speaking, what do you use?
Yes, I'm just going to try to pull up a slide here that will help answer that question that I didn't show for the sake of time. This was a study that was done by actually one of my cardiology co-residents when I was in Vancouver, Curtis Williams, and the group in Vancouver. It was published in Heart Rhythm in 2020. And what they were actually looking at was and they did a meta-analysis of all the studies that looked at healthy populations, looking at the amounts of supraventricular ectopy, as well as sustained arrhythmias, and what we would consider normal and abnormal. And what they showed was that ventricular ectopy was seemed to be more common as you advanced age. So about 40% of patients will have ectopic beats between 18 and 59 years of age, whereas if you're 80 plus, over 85% of patients had ventricular ectopy. They also showed that more ventricular ectopy appeared to be more common as you advanced age. So they have suggested that maybe instead of saying a overall cutoff of a percentage or a 24-hour burden, what we should be using is age-specific cutoffs. So on the basis of their findings from this meta-analysis, that was really only 10 studies, they suggested, that in patients who are ages 18 to 39, normal would be considered up to 500 PVCs for 24 hours, and abnormal would be greater than 500, and any non-CMVT would be abnormal. If you're 40 to 59, you could have up to 1,000 for 24 hours, and non-CMVT would be abnormal. If you're 60 to 79, or 80 plus, there wasn't quite enough data available in this group. However, it was not uncommon to find greater than 1,000 PVCs for 24 hours. And there's actually a fair amount of patients, there's up to, I believe it was 5% on average in those studies, who had any non-CMVT. So, we'd be more likely to tolerate higher burdens of PVCs and some non-CMVT on Holters in patients who are at the upper limits of age.
Excellent. I have a question. So throughout your talk, one of the themes that kind of recurred is the basal infralateral wall for scar and site of PVCs. So has anybody gone back and re-looked at those echoes to see if there is mitral annular disjunction, which can be sometimes missed on echo or a little tricky to see, just because we know that that's been associated with sudden death?
Yeah, for sure. That's a great question. So in both of the MRI studies that I showed, they did exclude patients who had mitral valve prolapse. Certainly, in the Muser study, they suggested that maybe this was just seems to be a common site for old active myocarditis, but they did actively look, as have we in all of our studies, look for any evidence of mitral valve prolapse and have excluded patients from those studies. But certainly, whether or not there is a small degree of mitral annular disjunction that is undiagnosed is certainly possible, and a good question. And I think a lot of the limitations in these MRI studies is that, particularly in the context of frequent PVCs, is they can be quite hard to read. And the inter-observer variability seems to be quite high. So, useful tool, but certainly, there are some limitations.
Question from one of your fellows, Dr. Wang. So any recommendations regarding the frequency of Holter monitoring if you're pursuing the watchful waiting strategy? For how long should we watch?
Yeah, that's a good question. In the PVC registry of BC, we were doing Holters every 6 months up till 24 months, and then annually thereafter. Certainly, I think every 6 months is reasonable, particularly in the first couple of years, just to get a sense of where their burden is going, to watch them quite closely. Obviously, if we are using 14-day Holter monitors and it's not a patch monitor, that's quite burdensome for the patient to do that every 6 months. So you may want to stretch that out. But I think, in the absence of any significant change in symptoms, if you have a few Holter monitors that do demonstrate stability, their EF remains to be stable, I think that you could probably lengthen those time intervals and just ask the patient to closely monitor for symptoms.
Excellent. Okay, well, that takes us. Oh, there's one more question. Hand this mic over.
Thank you for the presentation. So one question regarding the guidelines in the ESC for management of PVCs. So when there was symptomatic, what's special about the RVOT and fascicular PVCs that makes it more beneficial to have catheter ablation versus medical therapy?
Yeah, good question. As I kind of showed, particularly for the RVOT, the percentage of patients that will have successful PVC suppression, both acutely as well as long term, is highest in the RVOT. The risk of PVC ablation is low. So in those patients, particularly for RVOT PVCs, catheter ablation first line is reasonable. We're on the right side of the heart as well, so there are less risks of going to the left side of the heart, which would be stroke and systolic embolism, systemic embolism. Fascicular PVCs, I didn't really mention them. They do compose a very small percentage of PVCs, and that mostly pertains to patients who have idiopathic fascicular VT. I didn't really mention it, but in that flow chart, they do talk about PVCs or VT. Fascicular VT is something that is also quite highly amenable to catheter ablation, and is a type of VT that, if you could treat it, these patients have normal LV function, and you could avoid the defibrillator. And so that's a reason why you'd go for catheter ablation. Those patients may also be more sensitive to non-dihydroprionating calcium channel blockers. This is verapamil sensitive VT. So it's kind of a different population, but it's a very, very small percentage of these patients.
Excellent. Thank you very much. That was an excellent talk. Everyone, please register for Grand Rounds next week. Dr. Rebecca Hahn will be talking on the tricuspid valve and interventions. Have a good week.
Thank you.